Okay, we're going to continue on with Pediatric Respiratory Dysfunction, Chapter 40, and this is Part 3. When you look at the Croup Syndromes, there is larynx involvement. When involved, the situation is a little bit more dangerous and they have a risk of respiratory distress, airway obstruction, acute respiratory failure, and hypoxia. Acute Laryngotracheobronchitis is the most common form, which the edema occurs below the vocal cords. It's also referred to as a subglottic croup. If it's benign, it's rarely life-threatening. If it's acute, it is a respiratory emergency. See Table 40-1 on page 1208 and look at the comparison of croup syndromes. For nursing care, assessment of the respiratory status is to assess for signs of respiratory distress. For benign croup-like conditions such as congenital laryngeal stridor or laryngomalacia, some infants are born with weak airway walls and a floppy epiglottis that results in stridor on inspiration. Signs and symptoms are inspiratory retractions that lessen when the infant is placed prone or propped in side-lying positions. A respiratory infection and crying may make the symptoms seem scary to parents. Treatment typically resolves on its own as the child's respiratory muscles strengthen. And for education, you want to educate parents to provide the child with small feeding slowly and to place the child in a prone or side-lying position to help decrease recurrence and severity of symptoms. Speaking from experience, my granddaughter experiences this. She is 7 months old. And the way the pulmonologist explained it to my daughter so that it would be in terms that she could understand. This is just FYI for you in future, maybe teaching patients if they ask, or the parents, that the larynx, where the child breathes and exhales, inhales and exhales, is like a wet noodle. Now imagine an overcooked noodle and how it sticks. So sometimes when she's having difficulty, her larynx will stick, and of course the vocal cord area will close off. It folds in on itself, and it can actually cause obstruction. So now we're going to talk about epiglottis. We have the pathophysiology of it is basically edema. It's edema of the tissues above the vocal cords through supraglottic swelling, which results in narrowing of the airway with the possibility of total obstruction. This is a medical emergency. Its most common happens in the ages of 3 to 6 years of age. It usually occurs during any season. It's a sudden onset. The course and duration is rapid and progressive. And usually the causative organism is H. influenza type B. Classic symptoms include that the child insists on sitting up. This is in an effort to breathe. They tend to lean forward with their mouth open and they'll drool. They'll have difficulty swallowing. The child will appear wide-eyed, anxious, restless, and may have a frog-like croaking sound on inspiration. The child will not have a cough, and the throat will appear enlarged and reddened. The epiglottis will look like a beefy red thumb. Treatment. Treatment of choice is immediate tracheotomy or nasotracheal intubation for severe respiratory distress and a humidified O2 to prevent hypoxia, brain damage, and sudden death that is caused by respiratory arrest. IV antibiotic therapy, such as ceftriaxone or alternate cephalosporin, results in dramatic improvement within a few days. Corticosteroids are used in the treatment as well. Nursing care. Never, 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 ever use a tongue blade to inspect the back of the throat if epiglottitis is suspected. It may trigger a laryngospasm and result in sudden respiratory arrest and death. Also be sure to keep a trach kit at the bedside before any exam of the throat is attempted. Prevention is H. influenza type B vaccines, usually beginning at age 2 months and making it part of the regular immunizations. So for education, you want to teach parents the importance of children receiving regularly scheduled immunizations. You can also go to, I'm going to upload a video that you may watch here in a little bit, and it's called Baby Got Epiglottitis. For acute croup, most common of croup syndromes is caused by laryngotracheobronchitis. It's a viral condition typically caused by the parainfluenza viruses types 2 and 3, RSV, influenza A, and influenza B. Generally affects children that are less than 5 years of age. It is manifested by edema, destruction of the respiratory cilia, and exudates that results in respiratory obstruction. The barking cough typically follows an upper respiratory infection. Signs and symptoms are stridor. Symptoms of respiratory distress, hypoxia can develop, followed by tachycardia and diminished breath sounds. It can progress to respiratory acidosis and respiratory failure. A couple more videos will be uploaded for you to review. So treatment includes cool mist humidifier vaporizer, provide or encourage fluid intake. For hospital nursing care, they may have nebulizer treatment, IV therapy. You want to organize care to allow for adequate periods of rest. Frequent vital signs, including the O2 sat. Cardiorespiratory monitoring, administer O2 for hypoxia. Croup tents are no longer standard of care in most hospitals because it's actually hard to control the amount of oxygen that is actually being administered. For medications, they may have opiates that are contraindicated because they actually decrease respirations. So definitely sedatives are contraindicated. They can actually cause increased restlessness, which is a sign of increased respiratory obstruction, and sedatives mask these symptoms. Then you could have potential for nebulized epi. Racemic epi may be used to relieve respiratory obstruction. Could have corticosteroids that can be prescribed. It's used to reduce edema and prevent further destruction of the ciliated epithelium. Other treatments can include heliox, as helium and oxygen mixture. Helium actually decreases the force necessary and facilitates the movement of oxygen through the airways and decreases the mechanical work of respiratory muscles and reduces respiratory distress. Several trials of heliox have demonstrated no advantage over conventional modalities. However, other trials have shown it to be equally effective in moderate to severe croup when compared with racemic epinephrine. Heliox has been shown to improve symptoms in very severe croup that failed to improve with racemic epinephrine. Currently, the evidence is not sufficient to establish the effect of heliox in pediatric croup management. Okay, so let's talk about spasmodic laryngitis, or also known as spasmodic croup. Usually occurs in children between the ages of 1 to 3 years of age, and it could be caused by a virus, an allergy, or psychological trigger, or anything such as like GERD. Um, Onset is usually sudden, usually happens at night. Signs and symptoms can include barking, brassy cough, respiratory distress. The child will appear anxious. It usually can last about a few hours. By morning, the child appears normal and there is no distress. Treatment or nursing care is the same as for laryngotracheobronchitis. Let's talk about bacterial tracheitis. This is an infection in the mucosa of the upper trachea. Distinct disorder with features of croup and epiglottitis. Clinical manifestations are similar to those of laryngotracheobronchitis. May be complications of laryngotracheobronchitis, and they could have a thick, purulent secretions that result in respiratory distress. So for the treatment and nursing care, it is a vigorous management. You want humidified oxygen. They may get Tylenol or Motrin for fever, antibiotics, and the possible need for intubation or mechanical ventilation. This concludes part 3 of chapter 40 of pediatric respiratory dysfunctions.